Welcome back to Sapio. Last episode was the first part of my interview with Dr. Justin Houman from Tower Urology at Cedars-Sinai. We spoke about erectile dysfunction, a problem that affects 52% of men over the age of 40 and a surprising number of younger men as well. This week, we continue the conversation on men's sexual health, including topics such as premature ejaculation, P-shots, and porn. Yep, we're going to talk about all the stuff that men are embarrassed to talk about, so make sure to tune in.
In pursuit of health and wisdom, Sapio with Buck Joffrey.
So I think we kind of covered at least to a superficial level, I think people have a pretty good idea of erectile dysfunction in general, but I just wanted to talk about a few other things that are kind of related. And this one actually makes me think about the pump immediately when I think about it, is like refractory periods. Okay, so the time between when you have sex and then you can have sex again, it obviously goes down 20s to precipitously down through your 40s, 50s, and so on. Why? Why does that happen?
A couple reasons. So refractory time, I think I'd say there's two main reasons behind it. Number one, experience, right? Experience. So the things that stimulated you when you're 20, it's not going to stimulate the same way when you're in your 40s, 50s,
Yeah.
and 60s, right? So that excitement, not just from a mental standpoint, but that excitement from a physical standpoint, is just not going to be there, right?
Uh-huh.
That's number one. Number two, your erections are going to be weaker as you age, right? And we know with weaker erections, that threshold for firing or an orgasm, that threshold is a lot higher the weaker the erection. It's kind of like guitars, right? The strings of a guitar. If they're loose, it's gonna be, or more loose, it's gonna be harder to strum that guitar. Versus when they're tight, that sound is nice and crisp. So as the erections get weaker, the ability to orgasm, or that threshold, as I mentioned, is a lot higher.
Okay. So in theory, if you use, one of these medications, these phosphodiesterase inhibitors, you should actually be able to lower refractory time too?
It depends what the cause is, right?
Uh-huh.
Depends what the cause of the refractory, essentially it depends what the reason is. But yeah, if it's because you're having weaker erections, that could potentially help.
What can you do about it? Like if somebody, is there anything that people can do to improve, decrease refractory time?
It's so hormonally, there's a hormone called prolactin that could cause this, right? That could
Right.
cause elevated, that could cause increased refractory time. So if that level is elevated, we could lower that level. We could address the elevated prolactin, and that could potentially help.
So so prolactin is basically the pair bonding hormone, and presumably after orgasm it probably goes up naturally because you're kind of like you've done your reproductive deed and you're just you're bonding and prolactin's going up. So presumably that has an interference with that. So is the idea that it maybe that is going higher as people are getting older? Do we know if that's the case or?
We don't have, from what I know, we don't have any data on that.
Uh-huh.
And from my own patients, I can't tell you that I've seen anything with higher prolactin levels.
Mhm.
But
What about blocking prolactin though? Is that actually, when you mention, like in theory you can do that, I mean, how do you do that in practice? Is that?
you could, if it's elevated, right?
Uh-huh.
If it's elevated, even if it's mildly elevated, you could try, and in some situations that could help.
Mm-hmm.
But again, I mean, you have to account for the placebo effect when it comes to that.
Yeah. These guys who are using the pump, do they have any refractory then?
They do, right? They have but that's again where it comes.
Well, because now we're talking about orgasm,
Exactly.
right? Because they can, I mean, obviously they can, at some point they can Bluetooth themselves into erection at any given time, right?
Yeah.
But the question is, can they have an orgasm
They could
frequently?
It's going to be similar to as any other person at that age. The older you get, it's going to be harder to orgasm, and it's going to be hard to orgasm more frequently. And to me, if I could be honest, it's just this is just who we are, right? Evolutionarily, like we're made this way. The older you get, there's less effort. Our body isn't attuned. Our body doesn't need to necessarily do that. So our nutrients, the things that go towards building or creating orgasm, it's just not as important.
Yeah. Sort of depressing, isn't it? No, but you're not really needed. You're not really needed to reproduce anymore because the assumption is evolutionarily, if you're 50, you're probably already dead, and so you certainly don't need to be spending time, worrying about orgasms at that point.
You have to just cherish those few orgasms that you're having.
Um, that brings me to, I guess, another problem that some men have, which is they can get an erection just fine, but they can't orgasm. What's that all about?
Yeah, delayed orgasm, or anorgasmia. So that requires a little bit more work. Obviously, you want to see what the cause is, right? A lot of times, it's hormones are responsible for it. As I mentioned, weak erections are responsible for it. Medications like SSRIs, antidepressant medications, could cause delayed orgasm. So once you want to assess what's causing that, and then treating that, there's a number of treatments out there for it. Some supplements, some medications. That one's, as I mentioned, it's a little harder to treat. You kind of have to mix and match or try different medications to see what works best for each patient.
The opposite of that is, I guess, premature ejaculation, basically, not being able. First of all, why don't you define what that is? Because that's a pretty common problem.
So there's two types of premature ejaculation: acquired and lifelong. So acquired is something that you acquire over the course of your life, and then lifelong is something that you've had for as long as you could remember. Um, when it comes to lifelong, it's really there's three mainstays to it. Where you don't have the ability, you don't have the control to control your ejaculation. You're very much bothered by it. You yourself are bothered by it, or you're bothered that your partner's bothered by it. And then it's we'd say about less than 2 minutes, right? When it comes to acquired, you share the similar loss of control. You're also bothered by it, but you have 50% less of what you were before. So let's say you were able to have sex for, I don't know, 8-9 minutes, and now it's down to 3-4 minutes. That's considered acquired, right? Those are the two forms. So, anyways, yeah, those are essentially the
So
definition.
why does it happen? I mean, I guess, it depends of whether it's acquired or if you're born with it. But let's start with you're born with it. So like, why
Um,
or what's happening?
Yeah, so orgasm. There's numerous neurotransmitters that go through it, and really what it comes down to, or at least the prevailing theory, is that your neurotransmitters are so it's more serotonin based. You're just more sensitive, right? Some people are a little bit more sensitive. Those neurotransmitters, or the receptors, are a little bit more sensitive, and therefore they're getting it leads to premature ejaculation. That's the lifelong version of it.
Right. And how about the other acquired version?
So the acquired one, a lot of times it's contextual, right? It's in the context of certain settings, certain environments, certain partners. That could be one of the reasons for acquired. Medications also could be part of the reason for acquired as well. And then to me, hormone levels. You always want to check hormone levels for these guys, because when their hormone levels are off, whether it's their testosterone or estrogen, that could be one of the ways in which you could nudge this in the right direction.
Is that right? Interesting. So like having low testosterone?
Yeah, exactly. Or abnormal testosterone to estrogen ratio.
Uh,
By having that abnormality, sometimes correcting that, like I said, could nudge them in the right direction.
that's interesting. So what can you do about it? Okay, so if somebody has this problem, whether it's, I guess, again, it's going to be probably dependent a little bit on what the cause is and if it's been a lifelong thing or if it's something you can intervene in. But if it's a lifelong thing, somebody's like, gosh, this has been bothering my whole life. Can you do anything about it?
Yeah, so there's a number. We have a number of options, all the way, from creams to oral therapy. So first line really is creams, right? It's like a lidocaine cream, as we know. It's like a anal numbing cream. You apply onto the penis 5-10 minutes before intercourse. You wipe it off, and the hope is that it numbs the penis enough where you're not orgasming, or at least delays the time towards orgasm. Um, Works for some guys, not great, right?
Yeah.
Not great.
Yeah.
It's sometimes you put too much on, it numbs the vaginal canal, so
Yeah.
it's a little,
Yeah.
that one's not so great. After that, there's some supplements out there now that could potentially work. The different amino acids work to help address this.
Like what?
There's a company called Goodnight Mate that they have an oral supplement. It has a number of different neurotransmitters in there.
Good night, mate.
Mate, M-A-T-E.
This is an Australian company or
Yeah, it
something.
sounds like it. No, it's based here in Los Angeles actually, but patients have had some benefit with that. At least some of my patients have. When those don't work, then we start talking about SSRIs, right? The antidepressant medications. So we know that one of the side effects of SSRIs is the treatment dose is not just obviously the mental benefit, but you get the sexual side effects, which is delayed orgasm. So what we do is rather than giving it like Paxil, for example, rather than giving it 40 milligrams, which is the treatment dose for depression, what we do is we give it at 20 milligrams or 10 milligrams, where we get the side effects, but we don't get any of the mental impact. That works well. However, most of the time, guys have to take that daily, right? The
Yeah.
PR.
And what if they're already on SSRIs? Is that an option for them still? Like if they're already on, fluoxetine or any number of other medications, it seems like you don't really want to double it up.
You don't want to double it up and you don't want to add another one. This is where you have to
Right.
kind of talk to the psychiatrist or
Right.
prescribing doctor to see what you can do. So most of those situations, you have to talk about
Yeah.
some of the second line.
All right. So not ideal. So what's another option if somebody
Has these. So the other one is tramadol, which is basically like an opioid.
yeah,
But
but it doesn't really. Tramadol is the one that doesn't give you the opioid feeling.
it doesn't give you the opioid feeling, but still has some addictive qualities to it. So again, that's one of those ones where that's more PRN dosing. You take that as
So like an
needed.
hour before, kind of
Exactly,
thing.
an hour or two before. That kind of numbs you out, gives you the ability to maintain or have longer orgasms. And then now we also use something called Flomax or tamsulosin, which is we use it for the prostate.
Right.
We use that for the prostate, but that also has some added benefits when it comes to premature ejaculation.
And is that also a PRN type, like as needed, like 1 or 2 hours before
That's
kind of
as
thing?
needed as well.
No kidding.
Yeah.
Well, that's interesting. I didn't, and why would that work? Why? Because Flomax is basically kind of shrinks the prostate, right?
Well, it helps open it up.
Or it opens it up.
It opens up the channel. So how it works with premature ejaculation, to be honest with you, we don't know.
Going back to prostate issues, one of the things that I think was interesting too is we Cialis. You mentioned daily Cialis actually helps with benign, like with enlarged prostate as well, right? So why wouldn't we? Why wouldn't that be first line therapy instead of Flomax typically, or is it for benign prostate hypertrophy? If somebody's got a large prostate, you got all these other things that you can benefit with Cialis. Why wouldn't you do that always instead of Flomax?
So we offer it. We definitely
Yeah.
offer it, right?
Yeah.
Like if a guy has erectile dysfunction and he has a weak urinary stream, waking up at nighttime, incomplete bladder emptying, absolutely, to kill two birds with one stone.
If you have somebody on Cialis, can they also have Flomax, or is that a problem?
That you could, but you don't want to take them at the same time.
Right.
So you bottoms out the blood pressure a little bit.
Oh,
So generally
okay.
say take Cialis in the morning, Flomax at night.
Got it. Interesting. Okay, got it. All right. Other questions I have for you. I didn't want you to spend much time on testosterone because it's like, we've talked about it a little bit before, but isn't there some other benefits to testosterone for people? I keep going back to this idea in my head because I've been told by cardiologists that there's some benefit in, maintaining good testosterone levels. And so then going back with that in mind, like it just seems like, so then my question keeps coming back in my mind is whether there is potentially some role, maybe it's not a urologic thing, but optimizing testosterone even in asymptomatic people because it has other benefits. Have you seen much data there?
No. Well, I'll say this is, look, I'm a big believer in testosterone, right? The benefits of
right.
testosterone. I see it every day, right? Um, but kind of as I was mentioning earlier, it's very rare that you see a patient whose testosterone's in the 100s or 200s who has no symptoms of low T. It's very rare. I'm not saying it's impossible, but these guys who have the low number, if you ask them enough questions, they will say some kind of symptom. But let's say theoretically they don't, right?
Yeah.
You never want to treat the number.
Yeah.
Right. You always
Yeah.
want to treat the symptoms. So if they're perfectly fine, right, and they have a low testosterone, they're in the 200s, but they say they're perfectly fine, then there's no reason to treat.
At least from a urology standpoint, as of now. I mean, who
As
knows?
of now,
Right,
as of now,
right,
right?
right. Okay, it's interesting. So, okay, let's get to testosterone replacement a little bit. Not necessarily the numbers, but different ways that you can do it. Um, you said that, probably one of the most, it's going to be one of your most common causes, especially in young men. Uh, what are your options? Obviously, you can replace testosterone directly, but there's other things you can do as well.
Yeah.
So with the HCGs and Clomids and things like that, if you want to go through some of those.
Yeah. So the first question you always want to ask when a guy he needs testosterone, he needs a boost in his testosterone is, are you interested in fertility now? Right?
Uh-huh.
Because we know that testosterone replacement therapy will at least temporarily block the ability to produce sperm, right? It inhibits your testicles' ability to produce sperm.
Yeah. And the reason, just so people know, is basically what you're doing is it's a hormone that it's a feedback loop. So effectively, if you're adding testosterone from outside of the body into the body, your brain thinks there's enough testosterone. It's not sending signals back to your testes to make it. So that's causing them effectively to shrink.
To shrink and to stop doing what they
Right.
do, right?
Right.
Essentially stop doing what testicles produce sperm and testosterone. When you have synthetic testosterone going in, your testicles are like, all right, well, I don't
Right.
need to do anything.
Right.
So it doesn't do anything.
Yeah.
That's the first question you have to ask is, are you interested in fertility now? If you are interested in fertility, then your options are Clomid and HCG, as you mentioned,
Right.
right? So Clomid we use it off-label in men. Right? It's a fertility drug that's primarily used in women. So we use it off-label in men for hypogonadism, low testosterone. Essentially what it does is it tells the testicles to produce more testosterone, right? It stimulates the pituitary gland, which is in our brain, to release one hormone.
But it's not just testosterone, though, right? Or is it? Is it with Clomid? Isn't it doing increasing estrogen as well, or is it?
Yeah,
Yeah.
exactly. So what it does is it definitely increases testosterone. That testosterone can be converted to estrogen, but it also increases your estrogen levels because it's a SERM, right? So it's a selective estrogen receptor modulator. So it could block some of those estrogen receptors, therefore increasing estrogen levels. So it's kind of ironic. So that sometimes there's a paradoxical effect in some guys where their testosterone levels will skyrocket, right? They'll double, for example, but they're like, my libido, my sex drive has gone to dirt, and it's gone all the way down. It's
Yeah.
because we all need men. We need estrogen that drives our libido. But when
Right.
you're blocking that estrogen receptor, some men biologically, it really, really impacts them.
Yeah, I've heard about this before too. And the numbers on that are actually pretty important because I feel like, um, men who are on Clomid, all of a sudden their testosterone's doing great, and they're like wondering like why they don't want to have sex anymore. And then numbers that I'd read somewhere like it's 30%.
Yeah,
30% of men. That's huge. 1 in 3 men like who
yeah.
are going on this.
I've heard that same number. I've heard
Yeah.
upwards of 40%, but for me, I would say clinically, I probably see it in about maybe
Yeah.
10% of men. But yeah, it's not it's
Not
significant. Yeah,
insignificant.
it's
Yeah.
not insignificant. Well said.
Interesting. Okay, so and so if that's the case, why is Clomid not necessarily sort of first line treatment? Is it?
Well, it usually is just because it's an
Mhm.
oral pill taken every other day. But it used to be much easier to get. Now it's a little bit more difficult to get. But that used to be kind of the mainstay. Now, because Clomid is a little bit more difficult to get, we talk about HCG, right? So HCG,
Human chorionic gonadotropin,
right?
right?
So what this is an analog. This essentially acts the same way as the hormone that pituitary is releasing, called luteinizing hormone.
Uh-huh.
So that directly stimulates the testicles to produce more testosterone, and this doesn't have any of those side effects that we talked about, right? Of Clomid.
So it's producing LH directly. So or it's an LH analog. So basically, you are. What happens to the naturally produced LH then? It goes down.
As a result of the
Yeah.
yeah.
Yeah. So is that a problem at all? I mean, long term, or does it, if you come off of this, does your intrinsic LH go back up?
Yeah, it should go back up, right? It's not like you're shutting it down permanently.
Yeah.
Yeah.
Yeah. Okay. So that seems like sort of like a much better option in many ways to Clomid because now you're not dealing. I mean, do you have still the same documented side effects of Clomid of potentially decreased libido?
No, not so much because your testosterone levels
Yeah.
are going up. But regarding the decrease in the LH, the reason why you're giving HCG is because their LH is already low, right? So You're not going to give HCG if their LH is high because it's not going to have any impact, as you can
Got
imagine,
it.
because it acts the same way. So if their LH is high, giving HCG is not going to do anything for them anyway.
So in men who have low testosterone, how often or is the LH also low?
For young guys, it's the majority of the time.
Majority.
Yeah. If guys are under 45, 50, majority of the time it's because their LH is low.
Got it. So so those people LH is obviously one of those things that you're going to want to test. It doesn't seem like it's tested very often though. I mean, I know whenever I get labs, just basic labs, they're always testing testosterone, but I
Yeah.
don't see LH. I
No,
mean,
if your testosterone is low, you're supposed to do further investigation with your LH. I mean, I check it. I check LH.
uh-huh. Any side effects that you should be concerned about or think about when you're talking about HCG?
Um, Not really. HCG is quite well tolerated. If you're doing the right dosing, if your testosterone levels go up, your estrogen levels can go up as a result of the conversion. But otherwise, it's well tolerated. It's expensive though, and sometimes difficult to get. But it's
Yeah. Isn't it like a national shortage or something, or what? There was one.
um, it varies. Every like 2 years, there's some kind of shortage, and compounding pharmacies aren't making it now. At least now they're not. So you have to get the brand name, which can be quite expensive.
Got it. Got it. Um, what are the typical ways if you're actually using testosterone, if you're prescribing testosterone, what are the delivery mechanisms that are out there, and what do you prefer?
Once if fertility is not important to them, then we talk about the testosterone replacement therapy. So there's gels, there's oral therapy, so daily gels, right? Testosterone cream that you put on your shoulder. There's daily pills that you can take, and these are becoming more and more popular. Actually, the pills, and I'll talk about those. Then the injections, and then pellets. Those are the four main categories. The creams, the testosterone creams aren't great. Generally for older guys who don't really want to do something, but they don't want to really go to extensive measures. There's a risk of transference with the creams.
Yeah.
For about 2 hours afterwards. There's a lot of
Yeah.
it doesn't really penetrate very well.
Yeah.
The oral therapies, like as I mentioned, these are pretty common. Jatenzo, Talando, Kaisertrex. These are the three that are kind of booming right now.
And those daily,
Daily, twice a day.
twice a
Yeah,
day.
you take these pills twice a day.
Okay, like day and night.
Day and night. And there's good data that at least Kaisertrex increases your free testosterone, which is, free testosterone is really what the most important thing is. But those are the oral therapies. Then there's the injections where you directly inject testosterone once a week, sometimes twice a week into your subcutaneous fat or the muscle, ideally your subcutaneous fat. And then there's pellets. There's testosterone pellets that we place underneath the skin, usually the upper buttocks, every 3 months.
Why wouldn't people just all take pills?
For testosterone,
Yeah.
it's twice a day. I mean, historically, there was a lot of liver toxicity associated with
Okay.
these. So now these newer therapies, they're bypassing the portal system. So those are, that's why it's becoming slightly more common. But taking a pill twice a day,
Yeah.
people forget.
Yeah, I suppose. And so what's the most common in your practice?
Injections.
Injections.
For
So
sure.
1 or 2 times per week, and it's basically they do it themselves, inject like subcutaneous, kind of like, if you're diabetic or something, you're giving that kind of injection, or
Yeah, exactly. So
subcutaneous.
subcutaneously, generally, ideally twice a week, but at least once a week.
Got it. And then the other thing that I want to talk to you, so actually, you were talking about how if you take testosterone, you're actually you're interfering basically with that feedback loop. And so your testicles are shrinking. But with HCG, you actually could theoretically restore that LH, right? So could you add HCG to testosterone,
Definitely,
like, and effectively prevent shrinkage?
prevent shrinkage, so you guys who, they're like, I want to have a kid, but not now, or maybe in the next couple months, you could do it to preserve fertility as well.
Yeah. And do you do that typically in your
If,
practice?
yeah, it's some patients, I mean,
Yeah.
most patients who are interested in fertility, they'll just do the HCG or the
Yeah.
the Clomid.
Yeah.
But more so for testicular shrinking. Guys love HCG for testicular shrinking.
The other thing that I thought was interesting was the nasal version, Natesto,
Yeah,
specifically because it apparently doesn't seem to have as much effect on
fertility.
shrinkage,
Yeah,
yeah,
that too.
and fertility. So how does that work?
Um, so it's a nasal spray. You do it three. You're supposed to do it three
Three
times a
times.
day, and it increases your value. So it's basically a quick hit. Increases testosterone and then dives back down. Increases. So because of that small minor effect three times throughout the course of the day, you're not um, the axis, the pituitary testicular the hypothalamus pituitary testicular axis is not being disrupted that significantly. So your fertility is fine.
Yeah, just I mean, I guess for me the biggest thing is like, fertility and shrinkage, right? Like that's the big question and can you basically take this and if it doesn't create shrinkage or fertility issues, then why isn't that first line treatment? Is it just because it's three times a day?
Because it's three times a day. Guys get this postnasal drip. Yeah.
Oh.
And it's not consistent. That's the thing. We've used it, or at least I would tell you, like in real life, practically, guys are using it for like, they take a hit before they go to the gym, for example, right? It's more like it complements their other testosterone treatments, if that
Uh-huh.
makes sense.
Yeah.
I haven't had anybody who's actually solo used that by
Yeah.
itself.
Could you just use it just for workouts, period, and just do it one time a day for your workout? I
Yeah.
mean, is it in theory?
In theory,
I
you
mean,
can, and it
yeah.
does. It does give you that a little bit of a boost of
Yeah,
testosterone.
and that's not a problem physiologically to give yourself a little bump in the morning, and I don't.
Um, Depends, right? Depends, but generally speaking, no, because
Yeah.
it's not going to impact your PSA. It's not going to impact your hematocrit, your red blood cell count.
One real quick question also on testosterone testing, blood testing. So I had come across some literature basically talking about the changes in testosterone throughout the day. And I mean, I don't know if this is accurate, but from my reading, it can change up to 30% intraday. And I think that's like something that people ought to know about because if they're tracking their testosterone and they're taking a blood test one day at 8 a.m. and then the next time they come in and they're like coming and seeing somebody and getting their blood test at 2, you could have a huge change.
Yeah, so that 30%, so 30% is more on the extreme measure. So some people
Yeah.
there's varies significantly. Some people not as much, but we do know that your testosterone's highest in the morning, right?
Yeah, like around 8 isn't a
We,
peak
we
or
generally
something.
say we generally say check before 10 a.m.
Check
Right?
before
That's what we
10.
generally say. But the
Yeah.
earlier the better, right?
Yeah.
That's your peak number, and that's the number you really want to treat. Um, but yeah, we do know there's definitely variation throughout the course of the day.
Going back to porn and I guess masturbation. So I was listening to a podcast, pretty well-known podcast in the health space, and somebody very confidently said on that show that porn and masturbation absolutely have a negative effect on testosterone levels. Agree, disagree?
Um, I would say indirectly,
Indirectly.
indirectly. Um, yeah, I mean, we've done studies on, like for example, like intercourse, right? The buildup of intercourse up until orgasm. We know that testosterone levels are going up. Um, so, I mean, there's some, as you build up towards orgasm with masturbation, there may be some of that increase in testosterone, but then it normalizes afterwards. But directly, when we're speaking about masturbation and porn, I would say, um, what it ultimately, if you're doing a lot of these, if you're doing either of these excessively, what it does is it creates this. It's part of a greater overall picture where you're spending more time indoors. You're more of a sedentary person. You're not physically active. You're not doing the things that are necessary, the lifestyle things that lead to good overall health and good hormonal health. So that's why I say indirectly.
Yeah.
I haven't seen anything that directly, even remotely close to saying masturbation and porn decrease
In the
testosterone.
literature or in the
Well,
just
there's not much in there's not
yeah,
much in the
yeah.
literature about this.
Yeah, I was going to say because when I heard that, and again, this was a fairly well, established show. I was kind of surprised by it. And I didn't find anything in the literature about this, so I was kind of shocked that it was kind of delivered in that manner, that there was no doubt about it kind of way. But so, I mean, I guess at the end of the day, like what we're really talking about again is some of those things. I remember like athletes, hearing stories about athletes who wouldn't have sex for, 3 days before a football game or something like
Or like
that.
boxers,
Yeah,
yeah.
and presumably, if they're
Regarding that athlete thing, I think I had read something where it's about a week. 7 days is when, at 7 days, you'll see the highest peak after orgasm, and then
of
after
testosterone.
of testosterone, and after that, it's you don't get any more benefits.
So that it could simply be that. It could just be somebody who's masturbating like frequently is just not getting to their peak testosterone levels ever.
But the levels aren't. We're not talking about massive differences. You're not doubling
Yeah,
your testosterone levels,
yeah,
but it's a significant. It's a statistically significant increase, and no
right,
more than that.
right. Okay, last question for you because I know I've taken a lot of your time, but there's a lot of supplements out there. Tungat, Ali, some of these other things. Are any of them actually real?
Yeah, it's a very common question. So, Tonga Ali has become quite popular. I think Joe Rogan probably, I think,
Yeah.
popularized this. Fedocia, Agretis, that's another one I hear a lot about. The data on these, so I'll tell you Tonga Ali. There's some studies out there that really do show improvement in your testosterone levels, your serum cortisol levels. Like it helps with stress levels as well as boosting
Hmm.
your hormone levels. It's kind of like what HCG does. It helps more LH release, right? The luteinizing hormone release. So yeah, Tonga Ali, there's some data that suggests it helps, right? Again, anecdotally, I could tell you from friends and from patients, they like it. They
Mm-hmm.
like it a lot. Fedocia, similarly, the only thing is we don't know the mechanism of Fedocia too well. And then the third most common one is DHEA, right? DHEA is a
Mm-hmm.
precursor to testosterone and estrogen. That one works well.
It
Um,
does?
that one works. That one works. But all of these, when it comes to these, I would say, again, I could just tell you anecdotally, um, they're the type of thing that maybe lasts for 6 weeks, maybe, but like 1.5 months to 3 months, and then the effects are lost. So it's one of those where you
Okay.
kind of have to cycle. You have to mix them.
Yeah.
None of these are long lasting, and none of them have that sustained effect.
Wasn't DHEA like one of the drugs that athletes were taking? I think it was Mark McGuire
It might have been. I don't
or
know.
something. Yeah, I don't want to say anybody's name specifically, but I thought, wasn't this like people were using this as instead of steroids because they were legal and all that?
Yeah, I think it's part of it's part of like the doping thing. You have to be careful with that one.
Right,
Yeah.
right, right. Interesting. Well, what else? I mean, in closing, I guess the question is, like, for you as a practicing urologist in this area, like, what's your takeaway to people in general who have these problems? Is there anything else that you think that'd be useful for us to know?
Yeah. I would say, look, this is a lot, right? Men's health is, sexual health, reproductive health, hormonal health, all these things. It's a lot, but just keep it simple. Most of us, as long as you do the three things, eat well, sleep well, and exercise, right? If you're able to do those things, you should be able to maintain a good, healthy sexual, reproductive, and hormonal lifestyle. Like those are the mainstays. If you're not doing those things, if you have any of these issues that we're talking about, but you're not doing those, focus on those as the building blocks, as the foundation, and then we could talk about the where to go from there.
Fantastic. Thanks so much, Justin.
Thank you. Thanks for having me.